I think that there's a lot more oral options for patients, which is great for some of our patients that might have transportation issues, or even some of our compliance issues tend to come with coming to the appointment. So actually, one of the things that our institute is doing is our nurses are doing an oral medicine compliance study, where every time a patient comes to the clinic who's on any oral regimen, they go ahead and have them fill out a questionnaire. And one of my favorite questions on that questionnaire is, how many doses have you missed this month? And I think it's kind of shocking to see that most of our patients miss at least one or two doses, whereas when you ask them, did you miss any doses, they tend to say no. So I think that that's a nice feature. I've also noticed that with some of our more recent FDA-approved medications, patients are having better tolerance to the drugs and less side effects. So daratumumab is definitely at the top of the list for better tolerated medications. So really, one of the very few side effects that we only see very rarely would be an infusion reaction. Other than that, most of our patients don't have any complaints.
I agree with Chelsea that the oral medications are definitely adding some convenience for patients, but I do think some of the other emerging treatments in myeloma have some newer challenges that we're facing. For example, one of the newer oral medications, selinexor, has a lot of supportive care that comes with it, a lot of nausea, vomiting, weight loss, needing to come in for fluid support. So even though it's an oral medication option, it does then cause a lot of supportive care. And then additionally, some of the other emerging therapies, such as our antibody drug conjugates, we're seeing new side effects that we haven't seen before, like corneal side effects. So they're coming in for extensive ophthalmology exams. And then, of course, BiTEs and CAR-Ts are on the horizon. And while very exciting, it does bring these patients into the hospital much more frequently. So I think we're seeing some newer agents like daratumumab, ixazomib, pomalidomide that have a great side effect profile, but then we're also seeing the selinexors and CAR-Ts that have some more challenging side effects.
I would agree with you as well. And for us with selinexor, we tend to use that more in that relapsed refractory setting, and we're very aggressive with antiemetics and hydration for those patients. And the other thing to keep in mind with that is the thrombocytopenia that can happen with those patients as well. And you're right. I mean, the treatment regimens with daratumumab, pomalidomide, that combination itself is so well tolerated. Patients are unhappy when they have to come off of it. It was much easier to give when we went to the short infusion on it as well. So I think looking forward down the road to subcutaneous daratumumab will make that even better for patients. Our infusion centers are crowded and it takes a lot of chair time. But I think the other component to think about, patients they like having those choices, right? There is no consensus in the relapse setting. There are so many different ways to treat your patient, and bringing them into the conversation and taking into consideration their lifestyle, their working. Everybody isn't elderly who has this disease. So patients are working, they like the oral regimens, but we still at the end of the day want to pick the best regimen for the patient. And I think that's what the patient wants too. They want that most effective treatment, but they want a quality of life. And that's where we come in with managing those side effects for them. And with these multi-drug regimens, it's easy to dose reduce to keep patients on treatment.